Hello, everyone. I'm very sorry that this is an online talk. I'd much sooner be there in person, but on the other hand, the Oxford to Cambridge journey is a little bit prohibitive. So please bear with me. Do interact if you want to during the talk, but I appreciate that's a little bit harder than if I was there in person. So I want to talk about this, getting the right balance between diagnostic and predictive journeys. I'm going to, in genomic medicine. I'm going to say a little bit more about what I mean by those in a minute, but I wanted to start off by saying that I'm going to say really obvious things to public health experts. I'm going to say some really obvious things to diagnosticians or primary care or genetic specialists, etc., etc., or even to social scientists. But I hope that everything that will be obvious to some won't be obvious to all. And I think what I'm asking for is a better discussion between those different parties to see if we can get these issues right. So when I talk about these journeys, what do I mean? Well, I think I should preempt that by saying that large-scale genomic ventures, for example, Deciphering Developmental Disorders project and the 100,000 Genomes project, have delivered major successes and have really helped to reduce the length of time for the diagnosis of rare diseases. So previously, such diagnostic odysseys took years, and various papers have talked about median times to diagnosis, and sometimes they were between 4 and 10 years before a person with a rare disease could get a diagnosis, because they were going sequentially between different genetic tests and different specialists. Whereas now these whole genome approaches have significantly advanced that. And because of the major advances in technologies over the last 2 decades, it's now easier almost to do a whole genetic code analysis and cheaper to do that than it was to do some of the targeted genetic testing with your index of suspicion hat on, certainly than when I started in the specialty of clinical genetics. And there are now, as a result of those successes, there are now several pilots, I put in inverted commas, to see whether these diagnostic odysseys can be reduced by offering technologies to asymptomatic populations. So moving from diagnosis to screening populations. And that's very much the rhetoric that you'll have heard recently from government also, that prevention is better than cure. If we can detect things early, then we can save the NHS a lot of money. And on the top right, there's a report from 2024 about the global approach to reducing diagnostic odysseys. I think we can all agree that prevention is better than cure, but what through trying to prevent, we consign many more people to predictive or screening odysseys, where they require healthcare follow-up over many years, which could be costly and risky, both to the system in which they sit and to the individuals themselves, through the process of moving from diagnosis to screening. Now that to the public health people in the room, in the virtual room, will seem really obvious, but they are very important questions as we move from diagnostic settings to trying to detect diseases early. And I think they're important questions in general that are possibly not well addressed, but genomics poses particular challenges, I would say, partly because the rhetoric around genomics very much still relies on a notion of a genetic blueprint, something that very clearly says what's going to happen in the future. Now, I'm going to use journeys rather than odysseys, because I've had feedback that odysseys is an unnecessarily complicated word. So I'm really trying to look at, can we reduce diagnostic journeys without at the same time increasing predictive or screening journeys for many more individuals. And I'm going to use some of Rachel Horton's lovely cartoons throughout this talk. She's a Wellcome training fellow who's been looking at how we construct results from the genomic code. And here's somebody with a BRCA1 variant, ostensibly high risk, predisposing rare variant, on a journey over her lifetime between finding out and deciding what to do to modify her risk. And not even included on there is the possibility of surgery, and whether we should be doing that if we identify BRCA1 variant, for example, through screening rather than diagnosis. So, as I've said, there are some really good examples of where genomics excels. The DDD and the 100,000 Genomes Project have really helped to highlight that. And we know now that if we focus whole genome approaches on very high risk populations, then we can get a very high pickup. So if we go just to NICU, for example, neonatal intensive care units, then that really selects for a high possibility of diagnostic yields from whole genome sequencing, and that's where it should be used appropriately. These are symptomatic populations. That's really important to bear in mind. And the identification there of disease-causing variants with very high penetrance enables immediate management changes. And the thing to emphasize there is that the pre-test probability is high. Patient presents with clinical symptoms or a particularly concerning family history. We're looking for high penetrance variants. I'm going to say a bit more about that. There's a clear pathway to action, and there's a demonstrable clinical utility. Again, I'm going to tease away at some of these factors. So to start to think about why diagnostic success does not equal screening success, I think we need to think about a few different factors. Again, to some of you, this will seem really obvious, but I think it's worth spelling out. So the sensitivity and specificity of a particular test are the properties of a test itself. They're the same in any population. So when you hear about a genetic test having very high sensitivity and specificity, that's true for any population. But the predictive value of a test result is different in different populations. And the positive predictive value, i.e., the chance that if someone tests positive, what is the probability that they actually have the disease, depends on many different factors. Depends on the prevalence of the disease, really important. Depends on the penetrance of the variants tested, the gene-environment interactions, as well as genetic ancestral factors and other factors. I'm just listing some of them here. So thinking about prevalence, if we had a variant with a pretty good sensitivity and specificity, 95% in both cases, then if you're going to a NICU population where the prevalence of rare disease diagnoses will be about 50%, very roughly, then this is the sort of breakdown that you might expect for the value of your test. So if you do 1,000 tests, then approximately 475 will be true positives and approximately 450 will be true negatives. So the positive predictive value here is 95%, i.e. if you have a positive result, then the disease will be present 95% of the time. But if you're screening an asymptomatic general population where approximately 1 in 10,000 people will have the rare disease, and that's roughly the frequency of diseases expected in the newborn, in the generation study, the newborn screening project that I'll go on and say a bit more about, then those figures really change with this specific sensitivity and specificity. So here, if you've got disease of 1 in 10,000, you're testing 1 million, you would expect to see 95 true positives, but phenomenally more false positives. And that then translates to a positive predictive value of less than 1%, i.e. if you test positive in that population setting, disease will be present less than 1% of the time. Now you might say, okay, well, the sensitivity and specificity, that's for 95%, surely we can get that higher. And yes, we may well be able to, but what else matters? The penetrance and expressivity really affect the positive predictive value of a test. So even if you can nudge sensitivity and specificity up, then you need to think about variable penetrance. Not all people with a, inverted commas, pathogenic variant will go on to develop the disease. For example, BRCA1 variants that I've already mentioned have been quoted as being associated with an 85% chance of developing breast cancer in a lifetime. And variable expressivity means that even if you develop some features of the condition, let me squeak on my headphones, then it might not predict very well what type of disease you get. So people with the same variant might develop different symptoms, severity, age of onset. So your positive predictive value for having the disease might be high, but the positive predictive value for having severe disease or developing it by a certain age is much lower. And those values around penetrance and expressivity also depend on ascertainment. So we know most about the penetrance and expressivity of BRCA1 variants because we've studied them in people with breast and ovarian cancer or in their close relatives. And in that setting, we can say the penetrance is very high because they've been selected for presenting with a strong family history of breast and ovarian cancer. We already know, but we know in a much more limited way, that that figure of 85% is a lot lower if you go to the general population and look for BRCA1 variants. Now, that hasn't been done on a very large scale because it's not thought to be a cost-effective screening tool, so therefore our data is limited, but there is very good research evidence from, for example, large cohorts like UK Biobank, that it's significantly less than 85%. So the same test might perform brilliantly in a diagnostic setting, but be much less spectacular in a screening set, not because in a screening context, not because the test has changed, but because the population's disease prevalence, penetrance, and expressivity have changed. Another thing that we need to think about is that the environment interacts closely with our genetic background, and that affects a positive predictive value. To give you a very straightforward example, the same genetic variant produces different outcomes in different environmental context. So if you have an ApoE4 variant or two variants, and you have a very high cholesterol diet and a sedentary lifestyle, then you have a higher Alzheimer's risk than if you have a Mediterranean, an active lifestyle with exactly the same variants. So positive predictive value depends on the environment in which the person lives. And in screening contexts, it's often very difficult to account for those interactions, particularly when you don't know the exact environmental status or the exact environmental risks. So the positive predictive value in a screening context is averaged across all possible environments, making it very unreliable for individuals. And that's important in my example that I'll come to about polygenic risk scores. Genomic prediction often assumes that genetics operates independently, whereas environmental modifiers can substantially affect the penetrance and expression, and therefore this varies across environmental contexts. So I think this picture actually is quite interesting because the rhetoric of genomes being like a blueprint is actually quite inaccurate. It's more like a prism where developmental factors, environmental factors, random factors, for example, how your immune system develops over time, really influence the genotype, so that the phenotype that comes out after all that modification can range from severe phenotype to no phenotype at all from a single genotype. And I think that's often still quite misunderstood. Why is it so misunderstood? Well, the rhetoric around genomics, as I say, is a powerful one across the board. It's not just commercial interest trying to sell genetics as a powerful tool, as you can see here, but it's also how we teach genetics in schools. It's all about Mendel's P's, and it's very straightforward. And we always have very shiny, clear-cut images of genetics in any article about genetics in our media, for example. And I think that central picture of your genetic code with someone holding a magnifying glass up to it where it shows you from the genetic code what disease you will get, is a very common expectation that I very frequently see in the patients that come to the genetic clinic. So the impression to many people, not surprisingly, is that results are shouting out from the genetic code, and why are we being slow in the NHS to take advantage of that? I think when we think about that, it's worth considering what we mean by a whole genome sequence and what that actually tells us. So your average genome contains about 3 billion of these coloured letters that you can see along that double helix there, often abbreviated to G, A, T, and C. And a person's genetic code, all of us in the room, will have 4 to 5 million variations in that code compared to a reference genome. And of those 4 to 5 million variations, about 100,000 will be rare variations. So the evidence around what they do or don't do will be much more limited because they won't have been studied in large populations. On average, all of us, every single person, will have about 50 variants in their whole genome that have been in the past reported as disease causing. And we might ask ourselves, are they results? And are they results if I, for example, carry a variant for a rare childhood onset disorder, but I've got to my age without developing any features of it? So I think when we start with the genetic code, it becomes much more tricky to say what's a result from it and when is it a result, at what point in my lifetime is it a result. And I think that has really important implications for common conversations that we have about a right to know about our genetic code, and health professionals worrying about withholding information that they found in a genome from the patients who've had their genomes analysed. But hopefully we can have a bit more think about that in a discussion, other than to say a genome, the findings from a genome are less like looking for a needle in a haystack, or finding a particular gemstone that's been hidden, but we've just unearthed it from its being shrouded, and more like thinking about the code in a context and saying, in this particular context this has a meaning, but in that context it doesn't. And some more evidence that of why we tend to think about genetics in such a deterministic way is this nice analysis, again by Rachel and Leah, both in my group, who looked at how commercial stock images portray genetic test results. And they found that overwhelmingly visual representation, so any article that says something about genetics, even if the article itself is talking about the complexity of genetics, tends to be accompanied by a shiny, clear-cut, glitzy image, usually of a DNA helix, and I think that may well contribute to high public expectations of informativeness and certainty from such tests. And we just published that paper when the 10-year plan came out in July 2025, the 10-year health plan for England, which had just such a glitzy, shiny DNA helix on the front, and made a promise that or a promise of an aspiration that the NHS would create a new genomics population health service accessible to all by the end of the decade. We will implement universal newborn genomic testing and population-based polygenic risk scoring alongside other emerging diagnostic tools, enabling early identification and intervention for individuals at high risk of developing common diseases. Now, I've underlined some of these. The two I've underlined are the examples I'm going to go on to, and the bits in orange are to show you that although, of course, I understand this is an aspiration that has to be a headline, that there's a lot of confusion in this aspiration already. So mixing screening and testing, rare and common diseases. And there's quite a lot to unpack there about how we go from the early successes in genomics to this more widespread aspiration that will save the NHS money by early detection and prevention. So as I say, I'm going to use two examples of where I think we need to have a lot more discussion and thinking about these things: newborn genomic testing and polygenic risk scoring. So the first one hit the headlines a few years ago already, where various headlines suggested not that there would be newborn screening, but newborns to get rapid genetic disease diagnosis. And that headline was not referring to the NICU situation, where there would be a high chance of a diagnosis, but to the general population setting, just illustrating how difficult it is to get that conversation right. And the DNA breakthrough, revolutionary healthcare, could save thousands of newborn babies. Well, of course, doing genome sequencing and making a diagnosis probably won't save many babies. The examples of having a new treatment to save a baby that would otherwise die are very few and far between, above and beyond the newborn screening that we already have. So I think this illustrates part of what I've been saying, but it's worth saying again, that the technology advances or the outputs from technology are often conflated with the interpretation of that diagnosis and with the action that might ensue. Again, illustrating that screening and diagnosis really need a bit of attention in this particular setting, even though many people might expect the sensitivity and the specificity of a genomic screen to be set very high. So what's happening in the UK? There's a pilot of 100,000 newborn babies that's already started. Parental consent is sought during pregnancy, and cord blood is collected if they consent for their child. The screen is for more than 200 so-called actionable diseases. Parents can only take part if they also consent to whole genome storage linked to the health records of their child over a lifetime. And that would, of course, involve new consent from the child when they reach the age of majority. And I think this has great potential, and it's a fascinating study, but it is combining a research cohort and an intervention study in a potentially problematic way. It's certainly worth thinking about these issues. And what do we know about the evidence of the 200 plus diseases that we're looking at? Most are so ultra rare that they're unlikely to be discovered in the 100,000 pilot, that it'll require a much larger study to find them, in the way that I showed you with the positive predictive value table. You'll have to screen 1 million to at least get some results, but actually the positive predictive value will go down accordingly. We have one example from the US. So most of our knowledge about the effects of variants comes from finding them in ill people. We don't know the other factors necessary for them to have an effect. And so therefore we have almost zero large cohort data on variants in healthy newborns that will be picked up through this pilot. There's one example in the US and now in other countries globally on Krabbe's disease, which is a rare, severe enzyme deficiency resulting from a GALK gene variants. I should say straight away that this is not a disease that's being included in the pilot, but partly because of what I'm going on to say now, that this is a disease that in 2006 was considered for newborn screening to add to the heel prick test, but a US advisory committee advised against that because they thought there was insufficient information. But because of a very high profile person with a child with Krabbe's who really fought for this to be included, it was mandated in New York State in 2006 and in various other states across the US and now in other countries as well. So here we have some evidence. It's really unusual to have this degree of evidence because mandating these rare conditions is quite rare. More than 2 million babies in this interim evaluation, more than 2 million babies had been screened. It turned out that the estimated frequency of Krabbe's disease was 1 in 400,000, when the literature had previously suggested it was more common than that. Many novel variants were detected in the gene, but it was very unclear what their clinical significance was, and leading to lots of angst about what should be disclosed and followed up. The overall calculation was that the genetic variants linked to Krabbe's disease had a positive predictive value of 1.4%. So if you had a positive result, there was about a 2%, 1 to 2% chance that it was a real positive result. Of the 6 children with confirmed clinical signs of infantile Krabbe's, treatment has so far helped 1, so this is out of 2 million babies screened, but more than 500 babies who screened positive are being followed up regularly for possible late onset forms of Krabbe. So really illustrating here those new predictive screening journeys that are created by taking a diagnostic test to a screening setting. What are the costs of following up those 500 plus children for possible late onset forms of Krabbe, cost to the health system, cost to those children, and how do we balance that with the benefits for the one child that's benefited so far? Of course, screening programs require detection at an earlier point than someone becomes symptomatic, and where a subsequent intervention will change the course of that disease. And that's so difficult to determine for all the 200 plus in the pilot of the Generation study. We often assume there's a very high sensitivity and specificity, but there's always a trade-off between the two, even for DNA sequencing. And we have to therefore balance that more sensitive approaches will generate more uncertainty and ask more of already stretched health service resources, whereas more specific approaches will need to make really clear why we're going for whole genome sequencing and all the attendant storage costs that are quite significant over targeted testing for a particular or a panel of genetic conditions, when that would be cheaper and quicker and give babies and families the same information. And a quick example here of public thinking around this is evolving quite a lot. In the existing heel prick test for screening, we already screen for cystic fibrosis and we use limited genetic testing. We don't start with a genetic code, but if someone tests positive for a biochemical screen, then they will have some genetic testing. And for each true positive in that combination test in the current screen, there are around 5 times more babies with what's called CF SPID, which is cystic fibrosis screen positive inconclusive diagnosis. So these are uncertain results, and these often require several follow-up appointments before a diagnosis is confirmed or excluded. And when the Generation study, the Genomics England and ScienceWise went out to and initiated a public dialogue about newborn screening, in this particular case, the public said that they would want to have genetic testing to avoid missing any cases. But after a series of deliberations and reflections, thinking about that uncertainty created for many more, actually they changed their mind and preferred a more specific approach that would avoid missing some diagnoses, but have fewer labels with that uncertain CF SPID. And that's already with a genetic testing limited to biochemically positive children. So if we went just for an initial genetic screen, then those uncertain cases would be 10 to 100 times more likely than they are at the moment. And again, one of Rachel's cartoons that just illustrate how these unthought of much longer screening journeys might have a toll in terms of uncertainty and costs. Here's somebody who's had a screen positive for a heart condition, is being followed up over their lifetime, and when he's got older and got his own children, other family members have been tested. Actually, I can't tell the gender here, but the question is, but I've been followed up all that time and never been ill. So I think that's a nice illustration of what we need to think about on lots of different levels if we start with whole genome sequencing. I think I've said that, the current threshold is set very high for the heel prick test. So it's not quite clear why we don't expand the heel prick test with tandem mass spec, then we go to whole genome sequencing as the route to more diagnosis. Is definitely not the full story. Although I think the National Screening Committee evaluates any population screen very carefully and will only recommend such a screen if the balance of benefits over harms at an affordable cost has been demonstrated. Yet the impression is quite often amongst patient groups that the National Screening Committee is conservative or reluctant to expand screening. So interesting reflections that we went on to have a day about at the Centre for Personalised Medicine. That was a really fantastic day earlier this year, I think it was May this year, where we brought people from the Generation Study, Genomics England, and the patient organisations, the National Screening Committee, lots of different people together to have a conversation about how can we make progress with newborn screening. And if any of you wanted to look at the report, that's available on the CPM website. And there was interesting consensus from that meeting. So it's really important that children with symptoms of a genetic condition have timely access to genomic testing, and that screening should not be necessary to achieve this. That using genomics for newborn screening will lead to uncertainty for some families and for health services, and it's really important to prepare parents for this through careful conversations and to shift discourses that may set people to expect a great degree of certainty. Generating evidence around how genomic variation links to disease in a healthy population is hugely valuable for future generations, but international collaborations will be needed and the pilot of 100,000 won't be enough. Screening has opportunity costs, and we must ensure that when we're aspiring to improve child health through screening, we do not inadvertently divert resources from other important areas, and we must not widen disparities further by making screening seem more relevant to certain ancestral populations. We wrote about that in a BMJ article, and Rachel did one of our excellent podcasts on the CPM website. Again, you see it under the podcast tab about some of these issues in newborn screening. I'm just going to flash up another thing that the CPM has organised over the last few years is a school children art competition. This is a winner from last year or the year before, can't quite remember, and it's Scarlett, who is aged only 12, and with a very short brief about newborn screening and it personalising medicine, she came up with this beautiful drawing of a child trapped in their own DNA cage, and around the double helix in pencils above and below are some of the advantages and disadvantages of newborn screening, with the caption of lifesaver or life sentence, which I think is fascinating that a 12-year-old has grasped that tension quite so succinctly. Okay, my second example of using polygenic risk scores to screen, which was the other aspiration in the 10-year plan. What are polygenic risk scores? Well, they are variants throughout the genetic code, thousands of common genetic variants, so not disease-causing, but common variants that we all have and that have been identified through genome-wide association studies. These variants individually have a very minor impact on disease risk, but collectively they enable an assessment of the genetic component to common multifactorial diseases such as heart disease and cancer, to name but a few. For most common diseases, this can tell you at most 20 to 40% of the total risk, and it can't say anything about the other components of that risk. Socio-demographic, lifestyle, random factors, as I said before, may represent the bulk of the risk that aren't measured by these. Why am I talking particularly about polygenic risk scores and screening? I know that some people have said that I'm too negative about polygenic risk scores. I think I'm I don't feel negative about them. I think they have huge value on a population level. But the reason I want to talk about them to try and facilitate a realistic expectation is that they are presented as applicable to everyone. So know your genetic risk is so often associated with polygenic risk scores. They're actively marketed and promoted for population screening already, and they're being sold directly to consumers and pushed to primary care. And I think there are both implicit and explicit claims that they should be used for population screening. And what's interesting here is I think that, as I say, on a population level, or in the test itself, has high clinical validity. They do identify differences in risk distributions across populations. They have strong environmental modifiability, so a high PRS can be substantially modified by your lifestyle. This means the test result is unstable or unreliable for an individual prediction. If, as the 10-year plan aspires, we will have integrated polygenic risk scores at 40, then they might not predict the risk at age 60 if there are successful lifestyle changes in between. But they're often presented as if they have high clinical utility rather than validity, and the positive predictor value is very poor, with median detection rates around 10 to 15%. So Hingarani et al. Did a review of nearly 1,000 different polygenic risk scores across lots of different diseases, and that was the median detection rate across them all. So just because something is scientifically valid doesn't mean it's clinically useful for screening. Just to say that in a slightly different way, people may have heard about areas under the curves. What does that mean? AUC. This is showing you two populations, and underneath those two bell curves are your polygenic risk scores, represented by thousands of these dashes, each representing a variant. The blue curve is people who will not develop the disease, and the red curve is people who will develop the disease. And the polygenic risk score, in terms of its prediction, is only as good as how well those two curves are separated. You can see straight away that if you move them really close together, the false positives will go up and the true positives will go down. And the other illustration from last year is that if you take a whole load of polygenic risk scores that have been evaluated as robust on a population level, but then use them to predict individuals, then you find that some individuals, I think it was 20% of all the individuals who were tested across these multiple PRSs, had both in one score a risk in the top 5% and in another score a risk in the bottom 5%, showing that if you just have one, if we screen with just one polygenic risk score, how misleading those results might be. And another way of showing that is with these 100 people diagrams. So people often say, well, we're not using polygenic risk scores on their own, we're using them to help stratify screening. So women in the UK already get mammographic screening at the age of 50, so but why don't we, in the population 40 to 50, look at only those who are at high risk? So here we're saying we're looking in that 10-year population, and in those who are high risk from a polygenic risk score, we're offering extra mammograms, whereas those who aren't, they wait until 50 for their screening. And on first impressions, that might look really good, because look here in this diagram, I don't know if you can see my arrow, but in this diagram here, you've got 100 people where just less than one person based on a polygenic risk score tests positive, and about one person tests negative. But there's lots of false positives here, represented by blue. And it's similar sort of distribution if you just had a mammogram for everyone in that age group, or a slightly better red there. And then if you combine the two, you really reduce the false positive rate. And that might sound good, but you also dramatically reduce the positive rate. So actually your stratification works to some extent, but your true positive rates will go down. And just another way of trying to represent that with numbers from the UK, this is dividing people at age 40 into high polygenic risk scores and low polygenic risk scores, and then offering mammographies or not. And you can see that this will lead to the detection of 1,700 cancers that wouldn't be detected if you don't screen them, because then you can't detect them. But that's at the cost of 5,722 false positives, and you still miss nearly 600 cancers. And in both groups, the majority are unaffected. So we tried to summarize some of those in this paper in the BMJ, that realistic expectations are key to realizing the benefits of polygenic risk scores, and that we really need to be talking about absolute risks rather than relative risks. One famous UK politician thought that his life had been saved by learning about his polygenic risk score for prostate cancer, but actually what he thought was a very high risk translated to quite a low absolute risk. I'm not going to go into these horror stories here of having pre-implantation screening. That can maybe come up in discussion. So polygenic risk scores will always be limited in their ability to predict who will get a disease and who will not, which is not intuitive and potentially counter to people's expectations, that they only measure a small component of the overall risk. So I think communication is a really important aspect that we need to focus on here. I realise that I'm running out of time a bit, so I will bring those up in discussion. Just to say a little bit about ancestry, we must consider the population in which that was designed. Most polygenic risk scores that exist today have been refined on European populations, and I think it's not good enough, such as one recent New England Journal of Medicine paper said, here's a prostate cancer polygenic risk score that works really well, but not in black men, only in white men, because that has a huge risk of widening inequities. And for most common diseases, unglamorous but well-established risk factors like smoking, obesity, and socioeconomic deprivation matter more than a person's genetic background. Just to show you why we've got such lack of diversity in genomics, it's basically historical. We've got lots and lots of cohorts that were set up in the Europe that are used over and over again. UK Biobank, fantastic resource, but a really good example, 96% white, 4% non-white population that is studied globally now. So despite calls for better diversity, you can see the Eurocentric aspect of our understanding of whole genomes. This is genome-wide association studies, has actually got more diverse. No, hang on, less diverse. I'm going to skip over that. And again, many of you in the room will know that Wilson and Younger criteria are still the gold standard, but that genomic screening fails in usually 3 to 4 of those criteria established in 1968. So what I think we need to do is have much further discussion on some of these things that I've showed you earlier, the differences between screening and diagnosis in genomics, rare disease and common disease. In this aspiration of the 10-year plan, they're lumped in together, but the role of each in genetics is very different. And making it accessible to all is not good enough. It's got to be representable to all. So this is my last slide, I think. How can we acknowledge and respond to genetic determinism in many sectors of society to have different conversations about what to expect? What if screening cannot distinguish those who will develop a disease from those who won't in an effective way? How do we factor in lengthy predictive journeys, overdiagnosis, overtreatment, inequities, etc., etc.? Can we get better at combining information? So can we combine genetic and clinical and environmental data to improve prediction? If we're going to offer good lifestyle advice on the basis of a high polygenic risk score, then why not give that anyway? Why do we need to only give that with someone who's got a high polygenic risk? I think I've said that. I'll leave you with the all screening programs do harm, some do good as well, and of these, some do more good than harm at a reasonable cost, remains such an important line. We try to write a viewpoint in, or we wrote a viewpoint in the Lancet that genomics is no exception to that. So I leave you with that thought, but actually then my last slide is a nice conflation from David Cameron, summarised in the Times yesterday or the day before, which conflates diagnosis and screening, harm-benefit ratios, lead time bias, which we haven't even talked about, not specifically about genetic screening, but I think such a sort of poignant example of how we think that if something's useful in a diagnostic setting, it must also be useful in a screening setting. Thank you very much for listening.